Yeah, Dr. Aishwarya, we can start. Your audio is not there.
Yes, sir. Shall we begin, sir? Hello.
Yes, 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 we'll start.
Yes. Good evening, everybody. Good morning, everybody. Today's topic of discussion is on corneal topography. Introduction. Corneal topography refers to the study of the shape of the corneal surface and to extend the measurement coverage of the corneal surface beyond the capabilities of the keratometer. The modern corneal topography emerged via a series of developments, beginning with the keratoscope, followed by the photokeratoscope and then the video keratoscope. The video keratoscope, now called the corneal topographer, combines video capture of corneal images with computer processing to provide maps of the corneal surface power distribution. All of these use a more complete target to examine a wider area of the cornea than the keratometer. Cornea is the principal refractive element of the human eye. Cornea contributes 42 to 45 diopter of the total eye power. The anterior surface of the cornea accounts for the maximum refraction. The difference in the refractive index of air and cornea accounts for the maximum refraction. The difference between topography and tomography. Corneal topography refers to the graphic representation of the geometrical properties of the cornea, while the corneal tomography means it is the three-dimensional characterization of the cornea along with the thickness. So tomography also known as topography plus pachymetry. Corneal topography has been essential in diagnosing pathology, understanding the visual complaints from the radial keratotomy and photorefractive keratotomy cases, and evaluating new refractive surgery techniques. In screening for refractive surgery, corneal topography has become the standard of care. Since the introduction of Placido-based topography, other methods to measure corneal shape have been explored. These technologies include slit scanning tomography with Scheimpflug optics, raster stereography, scanning high-frequency ultrasound, holography, Fourier profilometry, optical coherence tomography, and grid-style reflection topography. One among those techniques is a Placido disc-based topographer. Placido disc-based topographers measure streams reflected from the anterior corneal surface. The first Purkinje image of the Placido target is digitized, and the radial position of points along the Myers is determined in intervals as close as every 1 degree. Computer algorithms then calculate corneal curvatures consistent with the shape of the Myers. Close spacing of Myers indicate relatively steeper areas of the cornea, while broad-spaced Myers overlay flatter regions. Although the algorithms used to calculate corneal curvatures vary considerably among different Placido-based topographers, with proper consideration, accuracy can be achieved. So this is the Placido disc instrument, which has alternate white bands and dark bands. The distance between the rings, the distance between the Myers is noted. If the distance is too crowded, it is considered as a steeper part, while if the distance is far away, it is taken as a flatter cornea. Although Placido topographers have good accuracy and repeatability and provide useful information on surface quality via their Myers, they are not without limitations. Only the anterior surface is usually measured directly, and this technique is sensitive to disruptions in the tear film. Excessive delay of image capture following a blink can cause normal spirocylinder corneas to exhibit irregularities due to tear film disruption. Thus, topography should be performed prior to drop installation and intraocular pressure measurement to maintain a regular intact tear film. Coming to slit scanning topography, slit scanning tomography uses a slit beam to capture light scattered from both anterior and posterior corneal surfaces. As during a slit lamp examination, measure corneal shape and thickness. Many slides are used. Many multiple slits are used. Around 40 slits are projected. Example. Based on slit scanning principle is orb scan. A series of slit beams are projected at regular intervals and image analysis is used to determine locations of points on the corneal surface. It is projects slit beams at 45-degree angles 20 times on each side of the video axis in 2.75-second intervals. So the slit scanning pattern, which has one projector and one camera. This projector continuously projects minimum 40 slits. Scheimpflug tomography. In Scheimpflug tomography, sagittal sections of the anterior segment are photographed using Scheimpflug optics, which increases the depth of focus and enables a simultaneous imaging of the cornea, anterior chamber, and the lens. Unlike Placido disc-based devices, Scheimpflug tomographers can analyze the very center of the cornea and image both the anterior as well as posterior corneal surface. However, they cannot image the ciliary sulcus, and slit scanning devices require extremely high resolution to detect curvature differences. The example of the Scheimpflug technique is a pentacam. The pentacam is a hybrid Placido Scheimpflug device that rotates around the eye 180 degree in 2 seconds, producing 50 images of both the corneal surfaces, that is the anterior as well as posterior, and forming 138,000 elevation points to create a three-dimensional representation of the cornea. Like the orb scan, the data must be translated and aligned to reduce errors due to eye movement during acquisition. The Galilei is a Placido dual Scheimpflug analyzer that uses two Scheimpflug cameras rather than one. Elevation data are averaged from each camera, which occupies the gaps in the Placido rings. To fill in the gaps, two Placido images are recorded with cameras oriented both vertically as well as horizontally. By using two cameras, measurements errors due to angle of orientation and ocular decentration are reduced. This is the image showing cross-sectional image of the anterior segment with a 3D surface representation. Next, coming to topography maps, local corneal dioptric power values can be represented graphically as a color-coded map with warmer colors representing high dioptric values, that is steeper curvature, and cooler colors representing lower dioptric power, that is flatter curvatures. Normally, corneas flatten towards the peripheral, with the rate of peripheral flattening varying significantly between individuals. The color-coded contour maps of each individual have unique patterns, and the topographies of fellow eyes tend to be mirror images of or enantiomorphs. The scale used to display corneal topography is critical for diagnostic purpose and to appreciate features that might reduce vision. Smaller dioptric intervals may lead to a distracting amount of noise, while broader intervals may smooth over and mask irregularities. Several studies have evaluated different color palettes and dioptric intervals, including the absolute scale, 9 the class or Wilson scale, and finally the universal standard scale. There are 4 types of maps in pentacam and are in reference of pentacam known as quad maps. The first among quad map is curvatural map. They give information about the patterns, symmetry, and skewing of the axis of the anterior surface of the cornea. The usual normal pattern is the symmetrical bow tie, where two segments are equal in size and their axes are aligned. The symmetrical bow tie represents a regular astigmatism. There also can be with the rule astigmatism, against the rule astigmatism, and oblique astigmatism patterns. These are the various types of patterns seen in the curvatural map. Uh, the patterns are symmetrical patterns, asymmetrical patterns. Symmetrical patterns such as round pattern, oval pattern, symmetrical bow tie, symmetrical bow tie with skewed radial axis. These symmetrical patterns are normal. They are seen in normal corneas as well, provided if the Kmax is less than 47. If the Kmax is more than 47, then there will be suspecting in ectatic disorders. Asymmetrical patterns such as superior steepening, inferior steepening, asymmetrical bow tie with inferior steepening, asymmetrical bow tie with superior steepening. These are asymmetrical patterns. They are also normal patterns. They are seen in normal corneas, provided if the degree in the skewed radial axis is less than 22 degree. If the skewed radial axis is more than 22 degree, they are considered as suspicion in the ectatic disorders. This is a Placido-based topography or image showing axial curvature maps with regular oblique astigmatism. The fellow eyes tend to be the mirror images of each other. This is the another image showing the first image shows normal corneal topography presented with axial power and the 1.5 diopter contour interval universal standard using a universal standard scale. Second image shows axial power map with 0.5 diopter contour intervals. This gives the appearance of irregular astigmatism in the normal cornea. Next, coming to axial curvatural map, the axial dioptric power map was the first standard method for representing corneal topographic data and is still the most common method used for routine diagnostic and screening purposes. Similar to photometry, the radius of curvature at each reflected mirror is calculated as if the cornea were spherical, causing axial maps to have a spherical bias with diminishing accuracy toward the periphery. Axial maps are used clinically because they relate corneal power to the corneal shape. The normal cornea is prolate in shape or steeper in the center and flatter in the periphery, which helps to compensate for the spherical aberration. Since axial maps tend to average the corneal curvature, some details may be lost. This is the image showing axial curvatural map. The first image is the instantaneous curvature, and the second image shows refractive power map. While the normal cornea is prolate with a steeper center and flatter periphery, the refractive map shows increased power in the peripheral, that is warmer colors, due to increased angle of incidence in incoming light rays. Tangential curvature map. Unlike the axial map, curvature measurement in an instantaneous or tangential map is not tied to the optical axis. Curvature is calculated from neighboring points using the second derivative of the surface shape. While instantaneous maps provide greater detail for detecting irregular astigmatism and may have greater accuracy in the corneal periphery, they may also introduce mathematical noise and fluctuations in the curvature values. Due to their high sensitivity, they are particularly useful in measuring optical zone size in eyes that have undergone corneal refractive surgery, as they emphasize the transition zone curvature changes. Next, coming to refractive power map, most clinicians are used to thinking of the cornea in terms of refractive power, since they relates to corrective lenses and amounts of correction in refractive surgery. While axial curvature maps convey shape information, they are not a true representation of the refractive power of the cornea, except centrally over the photopic pupil. Refractive power is calculated using Snell's law. Thus, as the angle of incidence of incoming rays increases in the corneal periphery, the power also increases. Therefore, the normal cornea will have a higher calculated power in the periphery than in the center, reflecting the natural spherical aberration of the cornea. Next, coming to elevation maps. So, the normal cornea is a prolate. It rises centrally above the reference sphere, resulting in a central hill. This hill is surrounded by an annular sea as the cornea dips below the reference surface. As we move to the periphery, the cornea rises above the reference surface, resulting in peripheral islands. Reference plane, various points on the corneal surface are compared against a reference plane, and any point higher than the reference plane is represented with warm colors, and points lower than the reference plane are represented with cooler colors. There are three various reference bodies available. They are best fit toric ellipsoid, and best fit sphere. The pentacam displays both the front and the back elevation map. The elevation on the front surface, that is anterior elevation map. While interpreting, we look at the values within central 5 mm circle on the map in best fit toric ellipsoid mode. Clinical interpretation is as follows. It is considered as normal if it is less than 12 microns. If it is between 13 to 15 microns, then it is a suspected pectatic case. If it is more than 15 microns, then it's a risk factor. In the posterior elevation map, elevation on the back surface, it is considered normal. The thickness is less than 17 microns in the central 5 mm. If it is between 18 to 20 microns, suspected case. If it is more than 20, then it is a risk factor. This is a Scheimpflug elevation maps of a keratoconus patient using different reference surfaces. That is anterior best fit sphere in the first upper left, and anterior best fit toric ellipsoid on the lower left, and posterior in the lower right. Elevation peaks become more visible as the reference surface more closely approximates the overall shape of the cornea. Coming to pachymetric maps display the distribution of corneal thickness across the entire measured area. These maps are available on any tomographic instrument, including slit scanning or Scheimpflug devices. The slit-based tomographers have shown that the thinnest areas of the corneal stroma typically lie inferotemporally to the fixation reflex axis. The OpScan was programmed with an acoustic factor that scales the optic measurement to be more consistent with ultrasonic pachymetry. OpScan central pachymetric measurements tend to correlate with ultrasound measurements, although they are consistently thicker by about 30 microns. The clinical advantage of tomographic pachymetry is that it provides a data-rich global map of corneal thickness, which exceeds the normal capabilities of manual ultrasound measurements and eliminates errors due to probe angulation or decentration. This is the pachymetry map of keratoconus patient, where the thinnest point, that is 470 microns, is seen at the center part of the cornea. Next, coming to difference map, it is very useful to compare corneal topographic maps at different points in time to ensure that both maps have the same scale, the standard scale, and similar steps for color distribution should be used for each. An alternate method for assessing topographic change or stability over the time is the difference map. Difference maps illustrate changes in corneal topography by subtracting one map from another. They are available for many different types of maps, including axial curvature, tangential, instantaneous curvature, elevation map, and pachymetry map. In difference maps, it is critical that both maps being compared are of the same type. That is, a difference map comparing axial curvature and a tangential curvature is clinically meaningless. Difference maps can document the progression of keratoconus as well as the topographic changes following contact lens discontinuation and keratorefractive surgery, among other uses. This map shows the difference map can be used to confirm the curvature change induced by laser treatment. The preoperative map shows oblique corneal astigmatism, while the post-operative axial curvature map shows flattening due to the myopic ablation with some central irregularities. The axial difference map reveals a well-centered ablation and ascends the central island. Coming to applications of pentacam, when to get it done. If the patient is complaining of frequent changes of glasses, defective vision even after refraction, patient with a long history of vernal keratoconjunctivitis, basic refractive surgery workup, abnormal keratometry readings, slit lamp examination, which is suggestive of corneal thinning. Screening and diagnosis of ectatic disorders. The pentacam system helps in identifying palm frustrated keratoconus and aids in diagnosis and grading progression of keratoconus and other ectatic disorders like pellucid marginal degeneration, Tyrian marginal degeneration, and also keratoblephus. The global consensus on keratoconus and ectatic diseases identified the following findings as mandatory to diagnose keratoconus, that is abnormal posterior elevation, abnormal corneal thickness distribution, and clinical non-inflammatory corneal thinning. Other findings suggestive of keratoconus are increased area of corneal power surrounding by concentric areas of decreasing power. Inferior superior power asymmetry, that is more than 1.5 diopters, and skewing of the steepest power asymmetry, and skewing of the steepest radial axis, that is more than 22 degrees. This is a map showing in the cases of pellucid marginal degeneration. The classic topographic pattern is of inferior superior steepening, which is most dramatic between 4 o'clock and 8 o'clock position with superior flattening. Described as the crab claw or lobster claw pattern, the thinnest point does not coincide with the point of maximal steepening. Then coming to applications of the pentacam in cataract surgery, corneal imaging plays several important roles in cataract. One of the most important being its use in astigmatism management. Regular astigmatism is generally corrected intraoperatively with corneal relaxing incisions or toric IOLs. Identification of irregular astigmatism is important in setting appropriate expectations for post-operative visual acuity and determining a good candidacy for surgical intervention. Historically, topographic measurement of astigmatism has been based solely on measurements of the anterior surface with several assumptions. The anterior-posterior curvature ratio is fixed. The posterior shape mirrors the anterior shape, and the posterior astigmatic component is negligible. However, recent tomographic studies have directly measured the posterior cornea, finding that it significantly contributes to total corneal astigmatism. In fact, neglecting the posterior corneal impact can lead to overestimation of in with the rule eyes by 0.5 diopter and underestimation in the against the rule eyes by 0.3 diopters on an average. Corneal topographers can also help recognize vision limiting corneal conditions preoperatively or explain unexpected post-operative visual outcomes in cataract surgery. Irregular astigmatism, dry eye syndromes, and epithelial basement membrane dystrophy are examples of relatively common conditions that can be identified using topography. In addition to their characteristic patterns on curvatural or elevation maps, examination of the reflected mirrors can provide valuable information on ocular surface quality and regularity. Topography can also be used to verify corneal refractive power in IOL calculations. This is especially important in eyes that have undergone corneal refractive surgeries. The ablation patterns of PRK and laser alter the anterior surface shape and the anterior posterior curvature ratio. The incisions of radial keratotomy alter both the anterior as well as posterior corneal shape. These changes greatly increase the difficulty of measuring the true corneal refractive power and estimating the effective lens position of the IOL. Several methods have been developed that use topographic and tomographic corneal measurement to improve the accuracy of IOL calculation in these eyes. Next, coming to refractive surgery, the corneal topography and tomography play vital roles in screening candidates for refractive surgeries. In addition to identify patients with irregular astigmatism, they also help estimate the post-operative ectasia risk. Indices based on anterior corneal curvature maps, pachymetric maps, the distribution, and elevation patterns have all been used to try to separate normal corneas from those with keratoconus, and even more importantly, from the contrasting keratoconus. Serial measurements can help determine topographic stability following discontinuation of contact lens wear as well as post-operative healing after surface ablation. It can help explain unexpected post-operative vision limitation due to conditions like irregular astigmatism, central islands, or decenter ablations. Topographic maps can also access the stability of corneal curvature in the event that a retreatment procedure is necessary. Topography guided laser refractive surgery has recently been introduced and may present advantages over traditional or wavefront guided ablations in corneas that are irregular or highly aberrated. Studies have demonstrated good refractive and visual outcomes following topography guided ablations in eyes with myopia, decentered prior ablations, irregular astigmatism, small optical zones, and keratoconus combined with the collagen cross-linking. This is pentacam, Bellin or ambrosia enhanced ectasia display showing form frustae keratoconus with a suspicious peak in the back posterior elevation map and abnormal corneal pachymetry progression from the center to the periphery. Corneal surgery, as with refractive surgery, topography can be used in corneal surgery to detect ectatic disorders such as keratoconus, pellucid marginal degeneration, post-LASIK ectasia. It can also help determine the visual significance of corneal and conjunctival lesions such as pterygium and Salzmann nodular degeneration. Topographic maps are valuable in characterizing and managing corneal astigmatism associated with penetrating and lamellar transplantation. They can guide suture removal, direct placement of corneal relaxing incisions, and assist in the planning of laser refractive surgeries. Finally, the corneal topography can again help to explain unexpected visual results by revealing the impact of conditions such as irregular astigmatism, dry eye, epithelial basement membrane dysfunction. This is an axial curvatural map of a cornea following penetrating keratoplasty. Before and after corneal relaxing incision, astigmatism was reduced from 5.5 diopter to 2.1 diopter with incisions placed along the 45-degree meridian just anterior to the graft host junction. Note that the scales of the both maps are the same to facilitate visual comparisons. Contact lens fitting. The pentacam helps in the improved fitting of the contact lens in irregular cornea. The topography helps to identify the corneal apex, cone diameter, corneal astigmatism, thereby helping the diagnostic lens selection. Conclusion, corneal topography and tomography have widespread applications in cataract, refractive, and corneal surgery. The technology can help diagnose corneal pathology, provide valuable information on the cornea's refractive power, and guide treatment. A wealth of information is available in many different maps for both anterior as well as posterior surface, including axial, instantaneous curvature, elevation, and pachymetry maps. Additionally, a multitude of numerical indices have been developed to help diagnose degenerative disorders, assess the risk of post-surgical ectasia, or estimate visual potential. Corneal imaging technologies continue to improve with increased resolution, faster processing speeds, and more accurate analysis of corneal shape and refractive power. These advances are leading to a better understanding of the cornea's optics and its role in vision. Uh, Thank you.
Okay, can you highlight basically when do you diagnose a person or a topography map as a map of keratoconus?
Yes, sir. In a patient with the keratoconus, in on maps, based on the curvatural maps, we see patterns, sir, and inferior superior. There will be inferior steepening. Most commonly, the steepening will be inferiorly, and the inferior superior steepening, the difference will be more than 1.5 diopters. Skewed radial axis uh, will be the degree will be more than 22 degree in the curvatural map, and in elevation maps, the value in the central 5 mm of the cornea will be more than 12 microns.
When you get a patient, we generally don't do pentacam or cirrus on all patients, but we do
Yes.
autokeratometry. So on autokeratometry, what are the indications that the patient requires further screening with Scheimpflug or cirrus?
Sir, if the K reading will be more than 47, and if the difference between the K1, K2 will be more than 2 diopter.
Yes, and also if there is any progression in the
Yes.
astigmatism, like last
Yes.
year it was say 1 diopter, now it
Yes,
has
sir.
increased to 1.5 or 2 diopters in astigmatism, because corneal astigmatism generally doesn't change that frequently. It is
Yes, sir.
same. Yeah. So if there is any change, if the steep value is more than 47,
Yes, sir.
then we should, and also patients particularly having VKC, you had mentioned it earlier. So those who are in habit of rubbing their eyes. So in that
Yes.
case also, if there is any astigmatism, then we should do screening to rule out
Yes.
any early keratoconus. Okay.
Yes.
Okay. Chalo. Nice class. Thank you. Any other doubts? Anyone?
No, sir.
Okay.